Well, good afternoon, everyone, and good morning if you are on the West Coast. Thank you for joining us this afternoon. I am quite sure that it's going to be very difficult to have all members join in the call. It's summer, and maybe some of them are on vacation. So let's get started and see if somebody else can join us. But in the meantime, I would like to do like a roll call and see who is on the line. Can you please introduce yourself and to let us know, give us your name, the health center that you are with, and your title. Let's start with Silkia. Hi, Silkia. Good afternoon.
Hi, good afternoon. I'm Dr. Silky Irizarry from MedCentro in Ponce, Puerto Rico. I'm the Quality Director.
Thank you, Silkia, for joining us. What about Tri-City? Who do we have on the line?
Hi, good morning. My name is Ryan Tanglao. I'm the Quality Program Management Coordinator.
Excellent, thank you. And we have somebody, a new member, I guess, from Texas. Can you please introduce yourself?
Absolutely. My name is Vicki Johnson. I am with North Central Texas Community Healthcare Center in Wichita Falls, Texas, and I am our Director of Compliance and Quality, and I'm also our lab supervisor.
Thank you, Vicky, for joining us. It's a great pleasure to have you on this group, and we're gonna talk a little bit about. We're gonna first give a brief introduction on the topic of what we've been doing for the last couple of months. As you may know, diabetes is a priority, a HERS priority, and we've been discussing diabetes for the last year. In our discussions, we've been talking about glycemic goals, social determinants of health affecting public housing residents, and how these social determinants of health somehow affects the diabetes control in this special population. We've been also talking about self-monitoring and lifestyle management and prevention. And some of the issues that patients have in general to manage diabetes. As you may know, according to the last 2016 the UDS report, health centers in general reported that 32% of diabetic patients have uncontrolled diabetes, which means that the hemoglobin AC is greater than 9 in this population. The average patient with uncontrolled diabetes in the United States is around 16%. So I'm sorry, 18%, and the goal, the Healthy 2020 goal, is to decrease that number for at least 10%. So as a result, HRSA, BPIC, the NCAs, and the primary care associations, and all the organizations providing training and technical assistance have been working on this particular health issue. It's been a year for us getting information from all the health centers, gathering best practices. We've been in contact with the American Diabetes Association. We've been promoting the tips, the diabetes is primary training. That's something that we plan to do in the future. We are working very closely with the American Diabetes Association and trying to provide that training at our national symposium. At the same time, we've been working with some of the primary care associations. Specifically, we have conversations with Massachusetts Primary Care Association and California Primary Care Association, who are very interested in this training, and we are trying to do some regional sessions in regards to diabetes and have some of the subject matter experts from the American Diabetes Association providing this training. Some of the best practices that we have gathered from all of you, we have a document that we've been working on, and the results have been presented at different national symposiums. We had the opportunity to go to California a couple of months ago and presented some of the best practices that we have gathered from all of you. And the NCAs, the 20 NCAs working with HRSA, have put together a document with all the best practices. That's a document that I can share with all of you. And basically is a compilation of all the best practices that we have collected from the health centers. As you may know, in case you haven't had your site visits from HRSA, diabetes is basically the quality measure that HRSA is going over with all the health centers. So if you haven't had your site visit, I believe that this is a good opportunity to listen from your colleagues and share some of the best practices. At this time, I would like to talk a little bit about microvascular complications and food care in primary care. As you know, this is a big issue for all the health centers, and specifically on the primary care settings. We are talking about 3 microvascular complications, retinopathy, nephropathy, and neuropathy, and as well as some microvascular complications such as ischemic heart disease, peripheral arterial disease, and cerebrovascular disease. So all these topics are very, very important. I've been reviewing some documents that I would like to share with you after this call. In regards to microvascular disease and complications, and according to some studies that I have gathered, diabetes in general reduces the life expectancy by 5 to 10 years. And the cardiovascular disease in general is the most common cause of morbidity and mortality. But the microvascular complications specific to diabetes are also very hard to deal with. And this is the reason why we would like to talk about these particular complications. As you may know, diabetes is the most common reason for renal replacement therapy, and is the common cause of blindness in patients under 65. So let me. Oh, okay. In regards to diabetes, there has been an increase in the number of patients with diabetes in public housing primary care. The total number of patients, or the total percentage of patients with diabetes is around 9.2%. So almost one out of 10 patients in primary care have been diagnosed with diabetes, and 68% of these have controlled diabetes, whereas 32% of them have uncontrolled diabetes. Now we've been talking about some barriers to successful management of diabetes, and that was one of the last conversation that we had. We've been talking about 2 big groups. There are some clinical limitations, and we have also been discussing some patient limitations. Just let me go back to my slide. Okay. In regards to clinical limitations, we've been talking about sometimes there is an underutilization of team support. There has been some clinical inertia. Some clinicians, when there is the time, or when a patient has uncontrolled diabetes, they try not to switch from oral medications to insulin. And then we have some patients that the other cause is treatment non-adherence. There are some psychosocial factors, some environmental factors, socioeconomic factors, and interpersonal factors. So I'm going to stop for a moment and ask you what the barriers to management of diabetes have you seen, and what have you been done? What are you doing to address this issue?
Hi, everybody. This is Ryan from Tri-City Health Center. We just had our first OSV, and we provided our barriers for diabetes care. And one of the barriers that we identified is our data itself. What we're doing right now is we are cleaning up our data in regards to proper diagnosis and a lot more. And currently, I can say like we are at 50% cleaning the data up. And after that, we want to make sure that we get accurate information in regards to the demographics and, the patients for diabetes care.
Thank you so much. What about, is there any problem with treatment adherence in California? Do you have any patients? I mean, it's sometimes one of the concerns is that patients either do not understand instructions due to health literacy issues, or because the patient has any economic issues, and they cannot get the medication. What have you seen in regards to treatment?
Yeah, we have seen that in our clinic, particularly with language barrier. So what we've done is we have a dedicated staff to care for that specific patient. And for example, if the patient doesn't understand English and he is Hispanic, so we have a dedicated person to, counsel the person in his or her language.
Okay. Thank you so much for sharing that information. What about things in Puerto Rico, Cynthia? What have you seen in regards to barriers to management of diabetes?
One of the problem here is adherence to treatment. Maybe it's literacy, but we give education to the patient and to their family members who take care of them. But I think maybe it's cultural because the way people eat here is very different from the States, and the food here is very badly for your health. One
Okay.
thing we contract an optometrist. She's in house. She's checking all of our diabetic patients. That's the first thing we did because we in retinopathy our compliance in the study was very bad. So we contracted an optometrist, and she's doing the test right now to all the patients who are uncontrolled. We reported 34.3 uncontrolled patients for the UDS in 2017. And we're going to develop a chronic disease control clinic. It's going to be outside this side. It's going to be in another place. So we attend those patients gladly with an endocrinologist and a peripheral vascular disease doctor.
All right. Thank you so much. That's very important. And let me move on. What about barriers in Texas? Any information that you or any barriers that you have seen in Texas?
Yes, absolutely. This is Vicki. And some of the things that we've seen, obviously the dietary issues, that's kind of a big thing. Health literacy has been a really big factor in what we're seeing here. And also just patient engagement in general. Those are some things that we've really kind of fought with. Some things that we have done to eliminate those barriers. First of all, we've got a research program that we just got approved for where we are actually going to see what interventions are going to actually have the most effect on the patient outcome. And so we just got recently approved for that. That's something we're going to be studying to see what works there the best. And we're going to be looking at 5 different cohorts on that. The other thing that we are doing is we actually do a health literacy assessment for our patients to determine what their needs are and how we can best meet those needs. And that has proven to be very helpful for us because we can learn about their language needs, but not only that, about their learning needs. Do they need something that's more pictorial, or is it something they prefer to see something in writing? Is it an internet-based type thing that they need? Those kinds of things. And so we're really trying to meet those learning needs where they are. The other thing that has been extremely helpful for us is we've integrated behavioral health into our practice as well. And the behavioral health workers, they are licensed clinical social workers that we do warm handoffs during the visit. So if a patient is uncontrolled diabetic, we have a standing order in place for our nursing staff to go ahead and do a warm handoff to behavioral health where they can do some lifestyle coaching and modifications and things like that, and that's worked extremely well. We saw a huge reduction in the number of uncontrolled diabetics, probably like by half of what we were originally. So that was a really, really big impact. The other thing that we've done is we have offered the DEEP classes through our local health department. Unfortunately, we have found that the attendance rate on that has not been very good. So that's probably one of the least effective things that we've had. And then finally, the last thing that we just recently have done, and we're real excited about this project, is we actually have started doing some group visits for diabetes. And we're going to see how that impacts patient care in the long run when we get people in there and they actually kind of form their own support groups and things like that from the group visit. We're going to see how that works out. But so far, the feedback that we've gotten has been extremely positive, and we feel like it's going to be very successful.
Excellent. And in regards to these group visits, who is providing the services? Do you have a nurse or a clinician or an outreach person participating?
So it's actually a team-based approach. So we have our primary care provider, which is the doctor or the nurse practitioner, whoever happens to be doing that group visit. Our very first one was with our chief medical officer. She did the physician services, and then we had nurses that were in there also to do the support work. To do like the foot exams and doing the vitals and what have you. The education piece of it, we did an integrated approach. So what we did was we had the provider giving education about their lab results, and some different things they can do with their medication and what have you. We had a behavioral health worker come in, and she did a piece about lifestyle modification. And finally, we also invited a dental hygienist to come in as well, who was also in our dental practice. And she came in and gave them a talk about diabetes and dental care, because that does have a huge impact on the A1Cs. And so we just took a really integrated approach from that. So,
excellent. Thank you, Vicky. And in regards to you mentioned something very interesting, and is the communication with the patient and the integration of all these services. Do you use your electronic health records to track patients, and if there is any way that you can do it through your portal
yes.
to communicate with the patient? What is your experience?
Yes, absolutely. So we use Greenway product. We use Entergy, and we do have patient portal that is set up, and we do have that where patients can use that as their preferred method of communication. They can talk directly back and forth with their provider through the messaging. They can get education through there, all those. They can get a copy of their records. All that stuff is available through the portal.
Excellent. Thank you, Vicky. Thank you so much for that information. And I'm going over the participants, and I've seen that we have some new participants. Who else is on the line?
Hi, Doctor. This is Sonia Tucker from La Maestra here in San Diego, California.
Sonia, good afternoon. Well, good morning to you. Thank you. Thank you for joining us.
And I am Phyllis Pei from Tri-City Health Center in Fremont, California.
Thank you so much for joining us. Who else is on the line?
And Joy Muckby from El Rio in Tucson.
Dr. Muckby, good afternoon. And do we have anybody else? All right. Thank you for joining us. We've been discussing the barriers to successful management of diabetes. This is the conversation that we had last session, if I'm not mistaken, probably 2 or 3 months ago. We've been going over some of the treatment and adherence issues and some of the clinical limitations. And one of the things that we've been discussing is communications with patients and the use of the electronic health records to identify patients, and the use of your portal to send messages to patients, specifically those who probably have uncontrolled diabetes, or they are not, they have an appointment and they are not going to the follow-up visit. So, Sonia, you and I were discussing this topic few days ago. Is there anything that you would like to share with the group?
Yeah, I think the last part I've been listening to everybody talk, and I do agree on the one of the barriers is definitely the communication with the patient and also the patient's literacy level. I think that's very important to address, because if we're able to make sure that the patient understands what the importance of managing their diabetes, and also at the same time we're able to identify was the literacy level. We might be able to use the different tools that we have available. So whether that is the electronic health records or even text messaging, if anybody's using text messaging as a way of education. I don't know if anybody has experience. We used a little bit of that in the past, where we were sending just healthy tips to patients. So we're able to customize that to the patient's literacy level, whether it's at general third level, fifth level, or fifth grade. I'm sorry. So whichever it is. Also, depending on the literacy and the capacity of the patient to be able to accept, understand, read, and have access to the internet, or having a smartphone. Also, that's something that we have been proactively assessing on our patients to see how we can better utilize technology to complement, not to supplement, but to complement what our providers are doing. So I really love the approach of the multidisciplinary team. Something that we have done here at La Maestra is incorporating a naturopathic doctor. So this doctor, so I heard the behavioral health doing the coaching and teaching on lifestyle changes. So we've used kind of the same idea, same approach, but with the naturopathic doctor being the person that will do the lifestyle changes and coaching. And we have also used behavioral health, but more for the support that the patient needs when they're barely diagnosed, or when the hemoglobin A1C is elevated or more elevated than the last visit. So kind of understanding why that happened and helping the patient from the mental health support, if you will. So that's basically what we've tried everything, and we decided that we also were going to have a multidisciplinary team, and within our primary care we have a diabetes clinic. So we have identified providers in each side that have a special training to treat patients with diabetes. They're primary care providers, but they have different trainings to the Diabetes American Association to be able to provide a more comprehensive approach to these patients.
Excellent. Thank you, Sonia. And Sonia, you were talking about text messaging, and for some of the colleagues here on the line, probably they don't know the diversity that you have in regards to population. Can you let us know? Do you have people either translating like a message that you have, and just like an overview? Can you discuss a little bit about the diversity and your population diversity to let the group know how many languages are spoken in that area?
Yes. So here at La Maestra, whoever doing here, I'm here in San Diego. San Diego, we are a resettlement. We had been designated as a refugee resettlement community. So we have here at La Maestra, we speak 28 different languages and dialects among the patients, and I'm on the staff. The patients speak more than 28, so we are constantly making sure that our patients are served, if possible, in their primary care language. Or in the primary language. So we have primary care providers that speak their languages. We also have ancillary staff that have been certified translators to make sure that they're able, and a lot of them have medical backgrounds where from the countries that they come from, so that they are able to use medical terminology in both languages in the most appropriate way. So we have been able, in my little department, in my quality improvement department, we speak 7 different languages. So I'm able to translate those text messages that originally come in English, and that they're just general information, not only because we have to make sure that we're HIPAA compliant and that we're doing everything by the law. So we're able to translate, and so we run reports in our EHR, and our population health management tool has allowed us to do that, run reports according to the preferred language, and being able to just send general education to the grade level that we have been able to identify those patients as, 3rd or 5th level. Most of our paperwork is to the 5th grade level, is the highest level that we have. And then we send it according to their language. So our primary languages are English, Spanish, Arabic, Vietnamese, Somali, and I believe I can't remember the 5th one, but I believe that one is Korean. So anyway, so that's what we speak here, and that's what we try to do. And we have limited to the 5 top languages, because otherwise we'll be, we will end up with 28 different, dialects that it will be hard to control. But that's basically the background in our organization.
Thank you, Sonia. And one more question for you. We've been also talking throughout these months about the use of telemedicine. Is this something? And I understand that La Maestra has been using telemedicine for other conditions such as hepatitis and chronic hepatitis, and providing patients with services from clinicians who specialized on Hep C specifically. And do you have any plan to use telemedicine on patients with diabetes, or is that something that you are considering?
Yes, that's something that we have considered. So just to complete, not only for hepatitis, we've also used telemedicine for, especially in the pediatric population, for patients with referrals to ENT and allergy and asthma. And so trying to leverage technology to make sure that our patients are compliant. So telemedicine is a big, is a big word. And trying to making sure that our patients are able to communicate with us. I guess in this point we have a barrier, which is the plan. And what the plan would allow us to do in California, and how we can get reimbursed for those visits in the kind of settings that we are on. So I don't know if if the other callers understand or are in the federal qualified health centers, but in California, federal qualified health centers have some barriers in regards to reimbursement. So we have to make sure that, and even with each plan, so each plan has different sets of rules here in Southern California, how we get reimbursed and what we can do and cannot do. But we are, what we have been doing, and we have also used telemedicine, the 3 examples that we gave before, those are examples where we have connected with outside providers, but we've also used telemedicine in-house. And what we're planning to do right now is one of our sites does not have a person that with a special training in diabetes. So we're talking to see if we're able to incorporate the patients from that particular site to the site that has the most effective provider. And we measure the effectiveness by in monthly basis by hemoglobin A1C, how many referrals were closed or the patients went to for retinopathy, how many patients are compliant with all the different characteristics that we have to make sure that we measure in a diabetic patient. So it's something that we have been talking about, to incorporate telemedicine internally, and we just had about 2-3 weeks ago, we got somebody, an ophthalmologist, approaching us to use store and forward telemedicine for retinopathy. And so we should be wrapping that up today. making sure that the plans will say that we're compliant when we do the picture of the retina and send it, store and forward to the ophthalmology to be read.
Excellent. Thank you, Sonia. And Joy, in El Rio, is is there anything that you would like to add in regards to the use of technology to communicate with diabetic patients, or any of the non-adherence barriers that you have seen?
Yeah, we're doing many of the same things that other sites are doing, although not the text messaging in multiple languages, so that's great to hear. I think for reaching out to patients who haven't been in, the portal and other technology hasn't been that useful because they're not checking it. But for patients who are coming in but are still uncontrolled, using the portal has been very helpful as far as having them send their glucose logs and blood pressure logs and other things like that in between visits, and then giving them feedback on adjusting their meds without visits. So that's been, I think, helpful at moving the process along. One of our big barriers that I think is remaining is working with the insurance companies, as far as, people will have a great plan and be doing very well, and then all of a sudden their insurance changes their formulary, or they decide something's not covered anymore, and then the patients just stop taking it, and by the time we see them back, it's been a few weeks or a month, and or longer, and then they're out of control. So we are working with our pharmacy team around trying to streamline the prior auth process. But I think a lot of work can still be done there. Seems to be a big barrier.
Excellent. And just out of curiosity, do you have a telemedicine program in place in Rio?
We do, but not for diabetes. Right now, we are using it for at-risk teens around reproductive health. So we have sites out in some homeless shelters and substance use programs that focus on youth, and are using that for contraception, STD testing, things like that, but not fully utilizing it for diabetes at this point.
All right. Thank you so much.
This is Phyllis Pay. I would have a question, and I have a contribution.
Sure.
The question is, the site that was already well into the text messaging, we are just now starting. I just wonder if you could share some of the scripts or messages that you send out.
I'm sorry, can you repeat the question?
We are starting the text messaging, care messaging program. We haven't even, written down our messages that we want to send out. But could you share some of the content of your messages and how frequently?
Absolutely. Okay, so
So we were sending initially, and I can send that the templates of what we use for education, so that you can have. I can send it to Dr. Leon, and he can send it to you. But so we were sending it once a month. And so for diabetes, we do it once a month, and we try to cover everything that is okay. So why it is important that you remind your provider to do a diabetic foot exam? What is important for you to come and and not to be absent from your visits, and just general information for diabetes. We also did it for hypertension. So we focused on those two chronic conditions initially, and there were other areas that we also touched bases. It was for cancer screening, so colorectal cancer screening and cervical cancer screening as well. But I can share the information and how often we did it for diabetes. Again, once a month was something that that we started doing, and then we moved to quarterly when we finally used all the text messages that that we thought they were important for the patients to have.
Thank you. And one of my
Hello. I believe that, we couldn't hear that your last words. I'm not sure if you're still on the line. probably there was some kind of technical difficulties. So hopefully she can rejoin us. All right, I would like to move on and talk a little bit about microvascular complications and what are you doing to address some of the issues. Um, as you know,
Hello?
yes. Hello?
Hello, I'm so sorry. I don't know what happened.
No, I'm sorry. And you were going to share something with the
Yeah.
group, and then for I don't know, probably there was some kind of interruption.
Yes. So we actually, part of the boot camp class, we take the participants on a walk around block, which is kind of a long block. It's 17 to 20 minutes. And before the walk, we take their blood sugar, and after the walk, we measure their blood sugar. And everyone sees how the exercise of the walk has lowered their blood sugar levels. So they're actually seeing it for themselves, witnessing it, and learning that what activity and exercise can do for their blood sugar. And then in the rest of the boot camp class, we do have a behavioral health person come talk to them about mindful eating and about triggers. And we actually have dietitians who demonstrate and share food, healthier recipes with them. Then there are games, and of course a little bit of education about diabetes. We're thinking of including a dental person to come speak about dental and diabetes.
Thank you for sharing that. I have two questions. How long have you been doing this activity?
Boot camp.
And the question is, have you been able to measure the impact of these classes?
We started in May, and we just now saw a couple of participants' second A1C measurements, and they did go down significantly. So that's what we did. We did one class in May and one class in July. My biggest concern now, as we talked with the team, is how to get people to come, and we don't have a big marketing budget. But when they come, they always give us great reviews. They love the class. They want another round of classes, So I don't know if the other sites have any suggestions on how to recruit people to come.
Any suggestions from the group on how to increase the number of participants?
So one of the things that we've been doing here in Wichita Falls, one of the things that we've been doing to try to increase the participation is that we have generated reports of people that are having, that are uncontrolled, for example, and we have a nurse that actually is calling them and talking to them directly about it. And then so we found that was kind of working okay, but when our behavioral health folks, when they started making the phone calls, that's where we actually got the bigger results.
Oh, okay.
So I was kind of going to say the same thing, maybe case management with, I noticed for us, the participation increased when we use the naturopathic doctor and her team. We've had the naturopathic doctor out for a few weeks, and we keep having people increasingly asking about that particular service. So I think it's just kind of trying, driving, not necessarily just moving away completely from the traditional approach of maybe the doctor and the nurse, but also just ancillary staff that are trained on how to talk to patients, and behavioral modification will also help to convince these patients to come in. And also we use the reward system. So if they come, we just give them a reward. So that's what we've used here.
Yeah, we do give them prizes, and if they answer questions correctly, they would get a ticket at the end of the day of the class. Not the whole day. We do have some small prize drawings at the end of the 3 sessions. This is cumulative there's a big prize. It was a crock pot, but not that big. But so to keep the incentive, to keep them interested in coming. But they have portion control containers. They have stretch bands. We actually do exercises in the class with them, besides the walking. We took them on a grocery shopping tour. So it's a lot of effort, and sometimes we get disappointed with the number of people who show up. We say they're coming, but then they don't come.
The other approach is Tri-City is very close to public housing developments, and even though you don't have the PHPC grant, you've been reporting public housing residents as patients. And one of the things that we are promoting here at the National Center for Health and Public Housing is to work with the Public Housing Agency and have some kind of MOU to provide some of the services, either close if you can go to the developments, or if they can share some of the activity. The Public Housing Agency can share some of the activities that you are doing at the health center. That particular approach has shown an increment in the number of public housing residents visiting the health centers in general. So if you haven't been in contact with the Public Housing Agency, I believe that this diabetes program is a very good opportunity to reach out to them and promote the activity. And they are very, very kind to disseminate the information among the residents.
Okay. Maybe separately you can send me an email of a contact,
Sure.
because I'm not aware.
Of course. That's something that we can do from here. Yep. All right. And Sonia, when you have an opportunity, send me the language that you use for the text messaging, and I will be more than happy to share that information with everybody.
Perfect. I'll do that.
All right. Thank you. Now, I would like to move on and discuss a little bit about the microvascular complications on diabetes microvascular complications. There are several guidelines. Specifically, this is taken from the American Diabetes Association, and even though you can read from different sources, the recommendations are about the same. In regards to diabetic kidney disease, the screening recommendation is to screen patients at least once a year. And in patients with type 1 diabetes with duration of more than 5 years, you have to assess the patient with and look for other comorbid conditions such as hypertension. The question for the group is how prevalent is kidney disease in your diabetic patients, and what you are doing to address these conditions? If you have any agreements with hospitals or other institutions, if this is something that you don't see, any comments on this? Vicky, what is your experience with diabetic kidney disease?
Okay, so we actually have quite a few patients who actually do have kidney disease. The problem that we have right now, and we've done a lot of education with our providers about it, is being really specific about, what stage of kidney disease that they're in. Mm-hmm. Because, when you start trying to strategize, how you're going to deal with these patients and how we're going to make sure that the referrals are all in place to make sure that they're getting in to see the nephrologist and all this kind of stuff. We want to make sure that those processes are effective. But if we don't have good reporting to go back to identify those patients, it kind of makes it hard to see. But we do know that there are a lot of patients who have kidney disease that are resulting from their diabetes. We know that that's a big issue, but we also are screening them early, with the microalbumin and the albumin to creatinine ratio. We're doing a lot of early screening and trying to make sure that they're on the appropriate medications to prevent kidney disease if they're not there yet.
Great, thank you. Thank you so much. Now, if you have a patient who cannot be either treated at the clinic. Do you have any agreement with either another specialist or hospital?
Okay, so we actually have a nephrologist here in town who
Oh,
takes
you
our
do.
patients. And so basically, we've not really had a hard issue with them taking our patients as far as for kidney disease. We have a really good nephrologist that works with us, and the hospital, we've got a good agreement with them as well, so that if they need to be taken care of, they're going to be taken care of. And so we just do what we can to make sure that those referrals take place, and make sure that we're identifying those patients appropriately that need that extra intervention.
Thank you. Silkia, what is the prevalent? Well, probably I'm not asking for a precise number, an accurate number, but how is diabetic kidney disease an issue in your diabetic population in Puerto Rico? And what you are doing to address the issue?
We transferred the patient. They're transferred for a nephrologist here in Ponce. He attended our patient because their insurance became a chronic disease payment, so they stopped to be our patient. We have to transfer the referral by referral to the nephrologist. We have a 7% of chronic disease in our diabetic patients, so it's high.
All right, thank you. Ryan, do you have anything that you would like to share? What about Dr. Mugby? Is the kidney disease an issue among your patients, diabetic patients?
Yeah, it is definitely a big issue. I don't know the exact prevalence, but it's very common, and especially the earlier stages, but really throughout the whole spectrum. And we do screen for it using microalbumin, and just really utilize our other diabetes resources to try to address the root cause.
Thank you, Dr. Mugby. Sonia, and what's the story in San Diego?
Okay, so for us, yeah, well, San Diego, we do have some patients with kidney disease, diabetic with kidney disease. I don't know the prevalence right now from the top of my head. We also use the microalbumin as a testing to try to catch any kind of changes early on. So at least what we have instructed our providers to do is they have to do it at least once a year. If there are any changes, they should be done every 6 months at least. We do have agreements with hospitals, with specialists to send our patients in. Again, there is a barrier just because the payer will determine where the patient will go according to the authorization that they would approve. That's one barrier. The other barrier is some specialists require extensive work done on the patient before they are able to see the patient. So that creates a back and forth between the primary care provider and the specialist, and that delays care. So we have been working for the past 3 years very closely with the specialists to know exactly what their requirements are for them to see our patients, so that we're able to send those patients or to send the referrer in with everything that they require. So one particular provider that we like very much, but they want the patient to complete a session of X amount of diabetic classes so that the patient would understand why this is important. And, just requirements like that, in my opinion, they could present a barrier to the patient. But again, we are able to, since we are knowledgeable about what they need, we're able to educate the patient and make sure that everything is in place before we place that referral, so that we move that referral as fast as possible.
Can I ask a question?
Sure.
Okay, so my question is, she mentioned something about the extensive workups and things like that need to be done before they go see that specialist. Do you provide, y'all listen, I'm talking about Texas stock here. Do you have on-site labs that do your draws for you, or do they have to go to an outside laboratory, or?
No, so we have in-house. So we have lab in-house. So we do everything in our community health center, and then we send it out to, we work with Quest and LabCorp. Yeah, those are the two that's the two the lab. But we do everything here. Hardly
so I'm
ever.
assuming that they would get the pit up, and I would assume they get the pit up pricing, the discount pricing if they pay cash.
Yes. We have to provide them sliding fee scale.
Yeah, we do the same thing here. So we offer, we have CPL is who we actually use, and they do pit up pricing for our patients. And what we're finding is that their discounts are just about as close to our sliding fee scale for our labs. And so we're finding that we're not having a lot of issues with people not getting them done because of cost, which is a good thing, because we were really concerned about whether or not that would be a factor. But fortunately, we've made it affordable enough where they can actually get these tests done, and that's been a really good thing. And so most of the time, because we know what our nephrologist is going to require before they ever go over there, our providers here will go ahead and get those ordered, and then the patient can get them done before that referral even happens.
Yeah, so that's exactly what we have been able to work. So it depends on the insurance company here. So if one particular insurance company contracts with XYZ, if it's a cash paying patient, it's a little bit easier because we can work with the specialist ourselves. That's when our MOUs and our agreements come in place. So what we've done, to help the providers, is we have manipulated our EHR and put all those tests that they need in one particular click. So they said, okay, diabetic testing, and once they click on diabetic testing for referral, all what's needed is going to be automatically ordered on that particular set of labs that are going to be that we selected for them. So trying to be as smart as possible and use technology to our advantage.
Exactly. We have predictive orders management in our system, and that it works very much the same way. And the providers really like that because the fact that they don't have to hunt and click. It's just a simple. You click one time and it's done.
Correct.
Thank you so much. That's very helpful. Now, from Tri-City, either Shanita or Ryan, is there anything else that you would like to add on kidney disease and what you're doing at Tri-City?
Right now, we're just incorporating the complications for diabetes in our boot camp classes. I think that's one of our process right now. But for the diabetes kidney disease itself, screening, I have to circle back to our providers and our champion provider for this.
Excellent. Thank you. Thank you for that. Now, let's talk a little bit about eye exams. And the screening recommendation is that patients should have at least a dilated comprehensive eye examination every year, and that's for a patient with type 1 diabetes. The recommendation is to have an initial dilated and comprehensive eye examination within 5 years after the onset of diabetes. I know that some of the health centers, based on what they've been sharing, you have some cameras. And so, what is what services are you providing, Dr. Silkia in Puerto Rico? I'm sorry. What is the services in regards to eye exams for diabetic patients?
Eye exams annually, when the first they are diagnosed with diabetes. Then every 2 years they have to have the test done. We have we prepare here a room, a clinic for the optometrist, and she have all the services here, or the machines that she needs. And we already have 20% of the patients have their eye exams done.
Do you have an ophthalmologist or a Optometrist? Okay. Right. Dr. Mugby, we've been talking in previous calls about some of the services, and you mentioned the use of retinal cameras. In addition to the cameras, do you guys provide the dilated retinal examination every year?
So we preferentially use the cameras if they can get a good view without dilating the eyes. And for the vast majority of patients, they are able to do that. And that has dramatically improved our numbers. For people who have insurance and have an abnormality with the screening, we just send them on through their insurance. Or if they can't get a good view with the camera, then they send those people through insurance. For people on sliding fee scale, they can dilate their eyes for the camera. And then if it's normal, they don't need anything else. If there's abnormalities, then we do have a network of people that will work with our patients to make sure that they get the follow-up care they need.
Thank you so much. And Vicky, in Texas, what screening services do you offer?
We do the retinal eye exams here. We have cameras on site that we use for that service, and we do it same day of the office visit, so they don't have to have an appointment. They just come in here. It's open access. They're going to get it same day as their appointment. We have a girl that's dedicated just to doing nothing but that, and we are doing this. The readouts are actually done. It's sort of like telemedicine, and so what we're doing is we're sending the images electronically to digital copies of the images are going to a organization out of New Mexico. In that organization in New Mexico, the ophthalmologists are actually reading those for us. And then if the patient comes back with an abnormal, then we're doing a referral to a ophthalmologist specialist here in town.
Great, thank you so much. What about Tri-City? What services, screening services, are you providing?
What we're doing currently is our A1C screening on site. We have our POC, or our point of care, but in regards to vision and for retinopathy screening, I think our vision clinic is doing that too. But for the frequency, I have no idea.
I'm sorry. You providing the service, or are you referring patients for eye exams? I'm sorry, I wasn't clear.
Oh, we have our vision clinic.
Oh, okay.
We have our clinic on site.
All right. Well, it's 2:00. We still have a couple of topics to discuss, but I'm not sure if some of you will be attending the VPEC webcast at 2:00, so I would like to be very respectful of your time. We can continue this discussion next time and probably add a couple of issues, clinical issues. So if you have any other questions, please feel free to send me an email. I will be more than happy to share with the group. And if times allows, then we can have our next call like in 2 months. I'm not sure if you guys agree with this.
Sounds good.
All right.
I'm good.
So thank you so much for your time. It's been very helpful. All the resources, all the information that you've provided is excellent, and we are going to make sure that all these best practices are posted to our website, and we are planning to share this information with other health centers. Dr. Mugby, just to finalize, I just want to mention that I was in California a month ago, and I presented some of the best practices at the CHI conference and had the opportunity to meet with some of your staff who were attending the conference. So I was very happy to see them attending that conference, and at the same time they were very happy to hear from all the best practices that you have shared with us. Thank you.
Great. they were excited.
Thank you.
All right. Thank you so much and have a
you.
great afternoon.
Thank
You too. Bye-bye.
Bye.